I think some of the most challenging cases for me are those where I have to play a role in reporting somebody to the Ministry of Transportation or Children's Aid, especially when it may be that person's first interaction with the mental health care and addictions world ever, and they've come seeking help, and I turn around and, in essence, betray their trust. And I imagine at times it can be triggering for a patient to have had that experience, and may lead to even more use of substances. And so then what good have I done them? As a health professional, it's heart-wrenching for me in the emergency department to have to tell a mother that I'm reporting her to the Children's Aid. And yet I do it on a fairly regular basis. I find that the best perspective to take is how one frames the conversation with the patient.
I often get called to see very difficult patients clinically, administratively, for an opinion. And I would say of the 15 or 20 times that I've done this, there's been an undiagnosed addiction problem. From something as simple as, when they go out onto our grounds, they meet up with someone who gives them drugs or cigarettes. And, so it could be undiagnosed nicotine withdrawal or craving that leads to aggression, or cocaine or alcohol. Most recently, I've dealt with some behavioral addictions that maybe masqueraded as psychotic disorders or mood disorders. So it's very interesting because the kinds of presentations we see on acute psychiatric units in acute outpatient settings are almost uniformly influenced by some kind of substance or other behavioral addiction.
So right at a point in life when an adolescent is working developmentally, all full steam ahead to separate and individuate from their family and from the adult world, they come in tremendous distress because their life is not going the way they want it to, and they have to come to the adult world, to care providers, to acknowledge that, and to actually then allow themselves to be given the help that's afforded them by the healthcare system. So that takes a tremendous amount of energy, and it really speaks to the level of distress when these young people are coming. Adolescents are notorious for dropping off the map when it comes to healthcare provision. So somebody with a chronic illness such as diabetes, they might be in really strong and tight control for their sugars until they hit adolescence. And then just that whole process of, I need to be me, I'm not my parents, I need to be separate from the adult world. And oftentimes their health care takes a tremendous hit. So again, these young people who are coming of their own choosing to get help are showing tremendous courage and strength to do that.
And here, the patients who are walking in, almost all of them have concurrent disorders, either past or present, as a significant part of their history. And this was pointed out to me early on by a patient who, when I was taking like a drug history, the patient turned to me and said, "Well, you forgot to ask me about marijuana." And this was like an 82-year-old man looking at me, and it certainly had not occurred to me, not something in my armamentarium of history questions. And so I had to go back to the books to look at, either the language I needed to use to ask the question, to get the responses I was looking for, and people might not be willing to tell me, or even just the reminder in my history taking to ask the questions, which had been left off my roster. It's sort of like I was perhaps originally trained as a resident to at least be aware of addictions, but the sort of middle class, upper middle class population surrounding Sunnybrook was, I just didn't get to practice anything I had learned as a resident, so I lost the knowledge.
The patient I saw a few months ago who presented to CAMH, to the hospital, admitted with suicidality and depression, spent 3.5 weeks in the hospital, was treated with antidepressant, and was discharged for follow-up in our clinic. And when I saw her as an outpatient in the clinic, she was not actually doing well. And she became suicidal again, and we readmitted her again. And then on readmission, she finally admitted and revealed that she was probably drinking 1 liter of vodka a day. Okay. and of course, she had a major problem with alcoholism. I don't know why or how she didn't go through withdrawal during her first hospitalization, but it illustrates that until that problem was identified and treated, addressing the depression and the suicidality was futile. So during the rehospitalization, treatment for the alcoholism was started in parallel with the continuation of her depression treatment. She was then discharged. The course was, of course, bumpy, but eventually she's now sober and remitted from her depression.
I've been in the psychiatry business for over 25 years. At the beginning of my career, I worked at the Clark Institute with ARF out the back door. And so I was expert in rerouting patients who had an addiction to say, no, you have to go to ARF4 first before I'll treat your mental disorder. And in fact, I trained many staff to do that. So I was part of the problem at the beginning. But increasingly over time, I realized that for me to effectively treat patients with psychiatric disorders, I couldn't ignore the addictions.
One that has always stuck with me has been one of my patients who I treated for his polysubstance use. And, you know, we were able to help him stop using, and I was able to help him, the team and I were able to help him stop using his heroin. He switched on to methadone. He did really well on methadone, but he started using cocaine. And once we started talking about what that was about, he said very clearly to me that, look, when I was using heroin, it would numb me out. The methadone doesn't numb me out the way heroin does, but cocaine certainly helps me cope with those demons that I'm dealing with in my life. And so we spent some time exploring these demons, and it became very apparent to me that this man had been traumatized as a child. He had depression for pretty much most of his life that had never been diagnosed and treated. And so what we decided to do was to get him the appropriate consultation, the appropriate therapy. In the combination of medications plus his therapy, he was able then to become a functioning member of society, because now he didn't need to use that cocaine, which was all he knew of how to deal with his mood and his feelings.